Hello, my name is Roger Blumenthal, and I'm editor-in-chief of the Dyslipidemia Clinical Community, which is available on CardioSource. It gives me great pleasure to talk with my longtime friend and colleague, Dr. Jennifer Robinson of the University of Iowa Lipid Clinic. Jennifer was one of the key people in writing these cholesterol treatment guidelines. And today, Jennifer, we're going to celebrate 5 years of hard work from you. So first off, congratulations. And I thought maybe we might focus initially on your thoughts on secondary prevention, people with established atherosclerotic disease. What are some of the high points that you want clinicians to take from this great document?
Well, thanks, Roger. We're very happy to have it see the light finally, and we're quite enthusiastic about the document because this was really the first attempt, not that previous guidelines weren't evidence-based, but it was really the first attempt to really do kind of the state-of-the-art systematic reviews that have been recommended by the Institute of Medicine. So we were very pleased to participate in that activity. And so as a result, we had very strict inclusion-exclusion criteria, only considered high-quality sources of evidence. And so I think there are a very strong evidence-based group of recommendations. That being said, secondary prevention, there's just a vast wealth of data from the statin trials that high-intensity statins, i.e. atorvastatin 80 milligrams used in, PROVE-IT, TNT and IDEAL, reduce cardiovascular events more than moderate intensity statins. And I think that's important for clinicians to know that it's really, they're going to get more event reduction and actually with a good margin of safety in appropriately selected people if they use high intensity statins in people with existing or clinical cardiovascular disease. We've introduced the term ASCVD, which is atherosclerotic cardiovascular disease, to really put the focus on what statin therapy is doing in terms of modifying progression of atherosclerosis. And so for those people who can't take a high-intensity statin due to other conditions, maybe previous statin intolerance, a moderate intensity statin like was used in these trials, which would be atorvastatin, Simva 2040, pravastatin 40, statins that lower LDL about 30-35%, also reduce events and are kind of a good alternative for those who can't tolerate high-intensity statins. We also talked about people over 75, maybe starting a moderate intensity statin on those people first. There just wasn't a whole lot of people over 75 in those trials that started statin therapy. But although if your patient is 75 and they're on a high intensity statin.
Those are all good points. One change, Jennifer, that is in this guidelines is that we now don't have LDL or non-HDL targets. You're one of the premier lipidologists and atherosclerosis experts in the country, and I guess so many of us over the years have, thought about adding a second medicine maybe to get to a non-HDL target. Perhaps you might clarify the writing group's thinking about whether to maintain non-HDL targets.
Right. Well, one of the two of our critical questions dealt with LDL and non-HDL targets. Previously promoted as less than 100 or even less than 70 in some people. And we looked and we just could not find evidence from the clinical trials to support continuing to recommend those as the primary approach to reducing atherosclerotic risk. And the reason is this: the statin trials used basically fixed doses of statins. While a lot of the people, for example, in those secondary prevention trials of the atorvastatin 80, many of them got an LDL less than 100. They got there on a high dose of a statin. They got there on atorvastatin 80. So the focus really needs to be on maximizing statin therapy. The question, and believe me, we talked about this every week for about 3 years, trying to come to some acceptable resolution. And what we really came to was there are actually potential for harms in trying to use goals. And what I mean that there's not, there's no trials to test it to show that it further reduces atherosclerotic events. But it also could potentially be harmful to a patient. For example, if their LDL is less than 100 on pravastatin 10 milligrams, well, they're getting really a suboptimal dose of statin, and they would be more appropriately treated by using a high intensity statin, if they didn't have any reason to be concerned about safety. So, we're concerned about that. Potential for undertreatment. We're also concerned that if somebody decided to use a second non-statin drug added to a statin, they probably may have to down titrate the atorvastatin 80 for safety. There's really not any safety evidence, even in short-term trials, for atorva 80 combined with niacin or fibrates, for example. So again, they would be denied evidence-based therapy. And then finally, the last part, and I think as our deliberations continued over that long period of time, more data did become available. As you know, AIM-HIGH was published, and it looked like the two strategies, we're calling them now, niacin plus simvastatin, simvastatin alone, both groups got some ezetimibe, equivalent strategies, similar LDL reductions in both groups, and despite additional reduction in non-HDL and triglycerides and ApoB, as well as some HDL raising, there was just no additional benefit from using niacin, preferentially to just, using a statin with or without a little ezetimibe. So I think the evidence as it emerged really suggests that there's not a whole lot of evidence to support adding a second drug to try to reach very low LDL targets, but also to try to secondarily reach non-HDL targets after the LDL target has been the LDL has been achieved. So, I hope there's future evidence. There's certainly the Improve It study going on, which should be ending fairly soon, to see if adding ezetimibe to statin therapy in people with relatively low LDLs on statin provides additional benefit. So, as we get more evidence, certainly I think the guidelines have left an opening for the use of non-statin therapy if there is evidence of additional atherosclerotic risk reduction. And I think that's the main point.
So that was a great summary, Jennifer. Let's switch to another area where you're an expert on, familial hypercholesterolemia. And if I read the guidelines correctly, it does say there that if you start off with LDLs greater than 190, then it is reasonable to add a second agent to the high dose of a statin, and maybe even potentially a third. So I was wondering if you might comment about your thoughts on familial hypercholesterolemia, about doing more than just a statin.
Right. And I think they're a special group. Certainly, they've been excluded from clinical trials, more recently, and so we don't have a lot of evidence of adding, a second agent in these people. But I think for them, we're talking about getting not down to 70 or 100. We're talking about getting from an LDL of 250 down to, to 150, and we're not even getting close to 100 on a high intensity statin. So I think for them, even though we don't have evidence, this is one group who could potentially benefit. Although I think throughout the new guidelines, we continually emphasize the importance of weighing the potential for risk reduction benefits, for reduction in atherosclerotic events, and potential for increases in adverse events, as well as other things. Some of these second agents added to a statin have side effect profiles, and it may not be acceptable. And so I think there's a lot to consider, and we're hoping that based on our recommendations, there will be future updates that can, help refine some of the decision making in some of these groups. But I think the panel felt that of any group, there was the potential for the greatest ASCVD reduction benefit in those who have, genetically high cholesterol levels.
Well, Jennifer, that was a great summary. As a member of the college, we're indebted to the hard work that you and Neil Stone and Alice Lichtenstein and others performed over these last 5+ years. And we just wanted to thank our audience today. And we hope that the audience will visit the dyslipidemia community frequently for ongoing information about dyslipidemia. It was a pleasure to interview Dr. Robinson, and this is Dr. Roger Blumenthal for the CardioSource clinical community on dyslipidemia. Thank you so much for your attention.
Thank you, Roger.